traumatic brain injury. And the common symptoms, it can be varied. It can be headache, dizziness, it can be irritability, behavioral changes, and many things are there. Out of which we have, like, our main focus is on the vestibular thing. Then apart from that, you can have oculomotor symptoms, you have a cognitive fatigue, you have a brain fog, you have a headache, even the bursting of migraine or new onset migraine, then cervical pain, cervical spasm, cervical symptoms, mood changes. So these are the usual symptoms what we come with it, and headache is the most common, followed by dizziness. Headache rate, it is almost said 50 to 70% of the patients may have dizziness. But what do you define dizziness? Like, dizziness is typically what we think of as vertigo. But these patients, they will not come typically with the vertigo symptoms. They may just have imbalance, they may have lightheadedness. I would like to go back to the traveling wave theory, which was given in the 1920s by George von Bexey. And this was how we hear sounds and all. And this still, I think, is probably the mechanism how the ear or the peripheral system or the inner ear is damaged. There's a force over here, force is over here, and then it travels. This is to indicate the contralateral side. There's a wave which goes, the pressure wave, it goes, and disruption, it goes and disrupts the inner ear. It damages the contralateral ear. Degeneration of the membranous vestibular labyrinth. Apart from that, there's the degeneration of the otolithic maculae. Then there's atrophy of the vestibular nerves. And then there's a vestibular hydrops, and these can lead to permanence of the symptoms. Like consciousness, where there's an ENT bleed is there, where there's any facial palsy is there, apart from other symptoms is there. And what is important in history, what we usually feel is missed is the drug history. Many of the patients, they go to the local physician, they go to the local centers, and by default, like what we say, har ek mal 60 rupees or 50 rupees. Same thing, whether the patient is 30 kgs, whether the patient is 70 kgs, 80 kgs, everybody is prescribed 300 mg of phenytoin or even loaded, which compounds sometimes patients come to us like imbalanced, they're not able to even walk few meters. So we're not able to understand whether it's the effect of the drug or whether it's the effect of this. Apart from that, there's a habit of people giving even Dexona, that is a steroid, and other medications. So it becomes very difficult sometimes for us to assess whether it's a drug or this. So that history, that part usually many of the times we miss it. So we ask for the prescriptions, and sometimes they are given, even if they do not have seizures and all, they are given the loading dose, even of 2 antiepileptics. Especially sodium channel 2 antiepileptics given, then it may worsen the dizziness or it may be the cause of the severe dizziness. At the picture, most of them by 3 weeks, almost 85 or 90% of them, the symptoms they resolve. These are known as early resolvers. But during this time, you need to be very careful about one thing, that is another trauma. Because what happens, there's alteration in the blood flow, there's alteration in the pathophysiology and in the brain, and a second concussion may lead to sudden increase in the intracranial pressure and worsening of the symptoms and even death sometimes. Because the brain is very fragile at that time and it is not stabilized. So this is the reason why even athletes and other things, they are not advised to immediately start or just go back. We have this concussion protocol, even in cricket and all, a patient, a batsman gets hit on the head with a bouncer, then they is assessed for these things. So this is one reason why the second trauma has to be avoided. Because MRI of the brain, CT scan, temporal and other things are advised for reassessing the patient, what is the cause of this. Because post 3 months, whatever symptoms are there, it is like more or less, it will start becoming permanent because the damage is permanent in these patients. The microvestibular trigeminal-sympathetic system, and this is where it acts. So you cannot see in isolation that we will give only for the balance, we will go for this. You have to see the patient in totality, and it has to be multimodal approach. So the key rehabilitation goal is that first is reduce the dizziness and visual motion sensitivity. Many of these patients, they have a lot of visual motion sensitivity. So unless confidence of the patients, even if the patient doesn't have major problems, especially those who are like coming to us after 3 weeks or say, there are a lot of confidence issues. They are quite fearful. नहीं अभी भी सर हम उठेंगे तो ये हो जाएगा वो हो जाएगा सर वहाँ पे चलेंगे. They always try to hold on to someone for their confidence. With us. So we use these mechanisms and these instruments in our arsenal. We have this to restore the confidence of the patients. So it's a multimodal approach: vestibular therapy, cervical therapy, visual vestibular integration, balance and gait training, neurocognitive, psychological support. The paucity of time, this was taken yesterday. So you can see here, these are the blaze spots, and this is for this visual and all. Again, this is again for the visual. Then this is for the balance. This is the Boshu ball. You can see here, this is the Boshu balls. So based on this, either the foam or the ball and this. And here this is a posture. We do, along with the posture, in few of the patients we do surface EMG. So we tell them that this muscle you need to contract more, and this we give the biofeedback in these patients based on this. Again, this is there for the gaze stabilization. And this is quite interesting over here. When you this one, yeah. So this was our ENG machine. Initially we started with ENG, then we moved on to VNG. So what to do with the ENG? We did not throw it away. We have started using it for this, the gaze and all. This is this you have here. So we have started using this. Then posture. This is new for the motion sickness and other things. This is still in trial. We are doing this. And apart from that, this is our robotic spinal decompression. Many of the patients, they have cervical spasm and they start keeping the head in a particular position. So this is quite beneficial in relaxing the cervical muscles and relaxing the tension of the patients. Profile and the symptoms, we prescribe this at our center. The home exercises based on what the patient has in this, and patients, and vestibular rehabilitation with symptomatic therapy. And always please keep an eye on the medications which the patient is taking. This is our team of vestibular rehabilitation, and thank you for your time.